Hello, I'm Jared Weiss. I'm a professor of medicine at UNC Lineberger's Comprehensive Cancer Center, and it's a privilege today to be joined by Dr. Sid Sheth, an expert oncologist in head and neck cancer, also at UNC Lineberger Comprehensive Cancer Center. Welcome, Sid.
Thanks so much for having me, Jared.
Any other data from the last year that you're very excited about?
Yeah, I will say it. Gosh, I don't know if I'm very excited about, but I do again want to give a nod out to our nasopharyngeal cancers. For most people who don't know, these are more common in Asia and driven by EBV or Epstein-Barr virus, so another virally driven cancer. And I just think there's been such a great amount of new data incorporation of PD-1 therapies into the palliative setting in combination with chemotherapy. So we're really seeing outcomes that are improving for these patients. And I think that definitely deserves to be recognized. And for the few patients that we do see in the US, whether they are EBV or EBV unrelated, I think this gives us more supporting data of how to treat these patients well.
And how about going forward? Anything you're particularly excited about?
Yeah, I mean, again, we're in the era of immunotherapy, so it's going to be very much trying to find the agents that we can combine with the PD-1 therapies, whether it's in the curative setting, as we've talked about, but also that there are some new agents that are trying to unlock how effective the PD-1 therapies are, whether they're naive or never been treated with that, or in the post PD-1 after they've failed this therapy. So a couple of pathways just as buzzwords are TIM3 and LAG, the LAG pathway. And we have a clinical trial that is now open at UNC that's looking at the TIM3 combination with PD-1. And so excited to see if that bores out some good results.
You're not going to talk about monalizumab?
Oh, well, Mona is always dear to my heart. I think it's the past year, maybe it's the pandemic. I just haven't heard a lot, but monalizumab is an NK cell inhibitor, and it's been used in combination with cetuximab. Here we go again, and some really kind of promising data again in phase 2 studies. So we'll have to see if there are more responses that come in this combination. And as I have been a strong advocate for, I think there might be a role for monalizumab in the earlier lines. And so we'll see if those studies do make it out.
I share your
bring it up, Jared. Can't forget my girl.
I share your enthusiasm. One of the mechanisms that one good thing about Mona is that it can increase ADCC. So I've realized I just spoke Greek, but let me rephrase that. It can work well with antibody drugs by mechanism. The other thing I like about this mechanism is that we have all these studies that take patients who've progressed on our currently available immunotherapy, our PD-1s, and then give PD-1 together with new drug after resistance, even though new drug doesn't really address PD-1 resistance mechanisms that we know about. One mechanism that we do know a lot about is the loss of antigen presentation machinery. So every cell in your body puts little copies of whatever it's making on the surface of the cell to show and tell to the immune system in case it's making something that it shouldn't, right? So if you have a cell infected with a virus, kind of an important topic these days, if you have a cell infected with a virus and it shows on its surface a foreign viral protein, that's going to bring in the immune system to kill that cell. That's why cells do it, right? One of the ways that cancer can hide from the immune system and evade our immunotherapies is losing that presentation, losing the molecules that are part of the show and tell apparatus. And NK cells, which are what drugs like Mona are active against, and there are other drugs against it, like the IL-15 mimetics, is that they kill cells that have lost HLA. So that's the other reason that I have excitement about this class of agents. So I do think there's good reason for enthusiasm there. Beyond that, it was an opportunity to tease you.
Yeah.
I'm enthusiastic about things that target more specifically foreign things on the tumor cells. So, I spend a lot of time working on how to predict an individual cancer's neoantigens so that you can build neoantigens being the foreign stuff that's foreign because it's cancer. Building a personalized vaccine. I'm very excited. Our personalized vaccine program hopefully will start treating people before New Year's. It's been a long project. Cellular therapeutics, where we modify patients' own immune cells to attack targets. And in HPV, one exciting thing is that unlike most solid tumors, unlike most HPV negative head and neck cancer or lung cancer, or pancreatic cancer, most of the tumors we treat, there are specific foreign things that are going to be shared from cancer to cancer because they're all caused by the same virus. And I'm excited to see things targeting that. The furthest along are vaccines. So there's sort of variants on the theme of the preventative ones. And I look forward to seeing more data on those.
Yeah, and I'm glad there's smart people like you who are working on these adaptive cell therapies, Jared, because that really is the next frontier, and particularly bringing CAR T cells and some of these TCR therapies into solid tumor oncology is it's going to be a daunting task, but I'm glad you're working on that. And I would say I would be remiss if I didn't bring up oncolytic viruses too. And I think you touched upon this, but an area that's near and dear to me as well. And so can we use genetically modified viruses, and based on the size of them, you can insert different things into them to help make the virus more effective and to help kind of stir up the immune system, and then add something like an immunotherapy afterwards to make it more effective. So there are a number of ongoing studies from a number of different companies that are kind of looking at this. And head and neck cancer is really wonderful in the sense that because it's very targetable directly, since we can see these tumors growing in the neck, for example, we can inject the virus directly without having to do kind of taking patients to the OR, for example. So I think head and neck is going to be a really important space for the development of oncolytic viral therapies.
Well, excellent. Any parting words?
Cisplatin is still king, my friend, and I'm hoping that in our lifetimes we're going to be able to say it's not anymore. So that's one, and two is that I think we have a lot of work to do in the HPV negative space. There's so much effort in the HPV positive cancers, and that's important. But we need to come up with better therapeutics for the other half of patients, and right now I think we're still failing them a little bit, and so our job and our work is cut out for us, and I know we're both excited about tackling that area. So how about yourself?
Gosh, you've said all the important stuff. I'm optimistic. I think we're going to increasingly cure a higher proportion of those who are curable now. And it's clear from recent developments that we're going to hurt people less in the process, that our cured patients are going to live higher quality lives for the rest of their lives. And that's been a trend we've already seen that I think is going to keep extending itself. And I think we're going to narrow incurable cancer to a much smaller proportion of people. I think as salvage efforts get better and as immunotherapy really gets out of its infancy and maybe into toddlerhood here, starts growing up, I think that's going to be something we talk about less and less and less, and very much more often we're going to get ourselves happily fired for lack of need. Personally, I look forward to opening a coffee shop.
I'm happy to be one of your baristas, Jared. So thanks so much.
That might be a happy note to end on.